Okay. If we look at the repair, I think this is going to hopefully address the gentleman's question that came up earlier. That's where we're at. But before we get there, I want you to consider this question. Given the following zones within the epiphyseal plate, the zone of calcification, zone 1, zone of resting cartilage, the zone of proliferation, and the zone of hypertrophy, can you put them in the correct order from the diaphysis to the epiphysis? Remember, the diaphysis is what? The shaft part, right? And the epiphysis is the end. So if y'all want you to come this direction. So see if you can write them in order right now. On your paper, or on your arm, or your neighbor's forehead. There's not already a black mark on it. Got it? Easy? Who's got an answer? Who's got an answer and ready to explain it? Yes, sir. Okay. You said C, but you said you're not going to explain it?
Well, I just kind of went across elimination, just seeing how 2 had to be, zone of resting cartilage has to be first.
Okay. Why? That's where it starts. That's absolutely true if you're talking about the opposite direction. So you're totally right for just a different question. Okay? But so this is asking, right, from the shaft part where the bone is added, working backwards. You with me? So it's the flip-flop of what he just said, and that's why I wanted to hear the why behind it. Because you got all the correct rationale, but you got to read the question very carefully. And if you don't, you're going to end up like, oh, that's a tricky question. No, it's just a real question. I mean, you need to read it. You know, it's like, how do you get to the store from where? Right? That's a relevant question. Depending on where you're starting from, it makes a difference on what your directions are going to be. So this question is saying from the diaphysis to the epiphysis. So the flip would be E. Can you explain why? He probably can explain why now. He knows where to start from. I don't know who said that. It was like this voice out of, yes? Is that you? E. E is correct. You guys are shy today. E is correct because it obviously is going to start for the question at the end, which is calcification. So 1 is first. Then you go to 4, which is hypertrophy, because you're working backwards. And then you go from hypertrophy to proliferation, because you usually proliferate before you, right, grow them bigger. And then the last stage would be 2, would be our resting stage. If I flip the question on Monday, and I want it in the order we introduced it in lecture, then you guys totally know what to look for. Right? Yeah. Okay. Perfect. How about this one? Which direction is the epiphysis moving? Well, that's tricky. The slide looks like it's sideways now. Yeah, because your bones they're always up and down, guys, right? No, of course not. So what happens if the patient's lying on a table? And that's this situation. Now you just need to figure out where's the head and, right, where's the epiphysis. So orient the histology. Which direction is the epiphysis moving? C. Why? I don't know. Okay. So C is not correct. So it would be what? D. Why? Why is it not A or D? Why is it not A or D, sir?
It's not A or D. One is look at the cell that I want to say that those are friendly with the cell.
Pardon?
I grabbed the name of like where area the C is.
Okay, that's bone.
Bone.
Yep.
As you move forward to the right.
Yeah, to B.
Uh-huh.
Yep.
Sorry, my right, or B.
So these cells over here are cartilage cells.
I'm not,
And these cells, so those are chondrocytes is the name of it. And these cells would be osteocytes, those are bone cells.
so as you go further, there's less and less of them, which means there's basically cartilage on the right.
That's correct. So cartilage is here. That means the epiphysis is this direction. Okay. Right? All right, so let's talk about fractures to your question. It's like just the two of us in lecture, him and I. I'll pick on more of you in a minute, okay, to get you guys engaged. These are the different types of fractures that we're going to talk about. There's a lot more. Many of you have had these. So let's define some of them. A closed, otherwise known as a simple fracture, is one where it's a clean break. And the break stays within the skin. Okay, so the bone's not protruding. That's a closed or a simple fracture. A compound fracture is one where the bone protrudes through the skin. These are the ones where people are like, right? They're about to vomit when they see, like, you know, the radius poking out of the skin. It breaks the skin. That's a compound fracture. Impacted is when you get bones that actually crush together, force together. A spiral fracture. This is a twisted fracture. This is usually one that you see in sports. Okay, a twisted type of fracture. Because of the complex movement that happens in a lot of sporting events. A green stick fracture. A green stick fracture is a term that's actually used to refer to that what happens in children. Because, like, you know, like a green limb on a tree, it's not quite done growing. And so the green stick fractures is a terminology used to refer to children who have a break. And a lot of times those green sticks might just be a twisted type of fracture and not actually splinter out. And then the last one, and then I'll get to your questions. The last one's called a commuted. A commuted fracture is one where it happens in the elderly, so the opposite of children. It shatters into fragments, likely because the bone density has been compromised. As we age, our bone density goes down, so it becomes less strong. So these fractures, the bone kind of just shatters out. Commuted is how you pronounce that. Yes, sir? So there's all sorts of different categories. So a stress fracture doesn't necessarily have to be a green stick. It just might mean it's a very small fracture and there are cracks. But the bone itself, the architecture of the bone hasn't been compromised. Okay, so you can have a stress fracture in adults, not necessarily just only in children. There's another question?
So if almost a great for a child is still developing, would that later in life cause like a deformation?
So it will, and I'll have a slide on that as well. I keep pushing you off. It's called a Salter-Harris fracture if it happens on the plate, the epiphyseal plate, and that's what we worry about. So I will address that as well here just in a moment.
I broke my bone when I was 5.
Yeah?
My arm was on.
Mine's a little weird, and I broke it when I was 6. But you can't tell because I have long sleeves on. How many of you guys have broken a bone? Let's see it. I don't see any like wonky-looking arms going up, but quite a few. Awesome. Okay, so how do we fix them? Listen to this gentleman's question. Stay with me, guys. Let's be come on. Let's be polite. Closed reduction. If you are going to fix it with manipulation, you're going to set the bone. Okay? You don't need surgery. You're not going to open it up. That's called a closed reduction. If it's an open reduction, that means you have to go in there and you're going to surgically place something, like pins or screws or appliances from Home Depot. Okay? They are just really fancy and super expensive, but they look like what you get like on aisle 9 in Home Depot. Okay, so if you're going from A to B, that is an open reduction because that's a surgical approach. The other option is, and it's used for both open or closed, is immobilization or casting or traction. So what we do is we try to, and this is answering your question in a series of slides, your first question, is we want the body to repair itself, and we promote that by setting the bone in the right place. And this is going to happen very similar to what we saw with wound repair and skin. We get a fibrous callus that forms. We see that fibrous callus that almost mimics what we call granulation tissue in wound healing of the skin. And so here's another parallel of how the bone and the skin fit together, is they both heal in a very similar way. They're both extremely well vascularized, dermis and bone tissue. And so they have the ability to heal very quickly. Those of you who raise your hands, let's see them again. How fast did it heal, generally speaking? 6 to 8 weeks. Okay? If it was aggressive and you had a series of surgeries, it might have been months beyond that. But it wasn't like 7 years. Okay? No, it wasn't that. It was pretty quick. But look at what happens. Step 1. You get a hematoma. You get a clot. That's a fancy word. We talk about that in the skin. For blood outside of the vasculature, and it clots. Well, because the bone is vascularized, there's a lot of blood vessels that can give rise to blood precursors, and stem cells can come out of the bone, and it forms a clot, number 1, step number 1. As the clot forms, it's soon replaced by a soft callus. That's a soft scar. Okay, this is a fibrotic scar made up of collagen. And the collagen and some fibrocartilage later will convert to this granulation soft scar, or soft callus. Then it hardens. The soft callus is replaced by a hard bony tissue. Just kind of like what you saw with bone development. And this is how our bones heal, to answer the question that was asked earlier. The osteoblasts lay down a bony collar. That should sound familiar. They come in and they start depositing the matrix, and this scar is converted to a hard callus. You remodel this slightly, you hollow it out in the middle and maintain, if it's a long bone, your moment of inertia, your medullary space, your ability to pack it with hematopoietic tissue. And I want you to kind of keep in mind that it started hollow and it ends hollow. Now, the question that was asked earlier, see how this is a little bit more, flashy at the moment? See how this is a little thicker here where the bone broke? Yeah. So the question was, it does tend to overcompensate. So it'll grow a little thicker than it was. And you can see that later in life in these patients. Now, the second question from you was, okay, what happens if it's in a kid and they break it on an epiphyseal plate? That wasn't your exact question, but that's kind of what you're getting at. So, very common, here's what happens with kids, it happens with a couple of mine, is kids fall, screen flickers, super annoying, and the kids fall and they catch themselves. And they catch themselves with their hands out, and their arms are not as strong and the bones aren't as dense, and they fracture it at the epiphyseal plate. So we call this a Salter-Harris type of fracture. We classify it into 5 different classifications if the growth plate has been affected. If it breaks anywhere else, you're like, who cares? Stop crying, kid. It'll heal. But if it's in this location, then you're super sensitive, and you rush them in. You kind of have to rush them in anyways. If they have a broken arm, they take an X-ray, and they know very quickly if it's a Salter-Harris fracture because of the X-ray. And so you can see 1 through 5 classification. Do you have to know these on Monday? No. But let me just show you as you move on in your studies. The 1 is the fracture really is a displacement of the original plate. The 2 is the plate is displaced and then a component of the proximal bone. Here it's the distal bone of the plate. Here it's both in a 4. And in a 5, it's actually, instead of them displacing away, they actually are smashed together. So the most common are actually 2 and 4, just in case you're curious. So what we worry about is there might be some stunted limb development if you don't take care of it. If you can't help heal the growth plate, the limb could grow in a stunted fashion, or you could actually have like a twisting of the limb or of the bone if it's a short bone. Some kids have broken fingers early in life, and then it kind of grew a little like, right? Or it's shorter than the other one. Like, what happened there? My brother slammed my finger in the door. Because that's what brothers do. That's how they show love. So you worry about the twisting if it becomes fractured. So, Carrie, do you mind dimming the lights just a tad? Because I was going to show this. And this would be helpful if the lights were a little bit lower. So this is a Salter-Harris fracture. you can see in this wrist, this fracture here and this fracture here. And the reason it's Osteoporosis is here's the plate. Okay? So, and this is another one that's down at the ankle. And you can see here's the plate, and here is the Osteoporosis fracture that affects the plate. So they watch it very carefully to see if it's going to be a problem. Okay? Another example, why we have our lights down, this is a spiral, or otherwise known as a torsional fracture. This is a skiing accident. Remember I said sporting accidents are spiral or torsional. So this is the tibia in the patient. And this is the right tibia, and you know that because there's a big R right here, of course. Okay? But you know that because the fibula is on the lateral aspect, of course. So how do we fix some of these? Gary, if you bring the lights back up, I think we're done with the x-rays for a while. If you look at immobilization devices, these happen in extreme cases like these torsional fractures in skiing accidents. Maybe you've known people that have like a really aggressive break, and they have like this like appliance that they're carrying around with them, right? You're like, hey Rob, you're right? So this is real, and these go in to immobilize the bone as it heals to help guide the bone. It's not enough that you're going to set it and you did an open reduction. You actually want to stabilize it so that, you know, if the kid in this case, without this fixator, maybe the limb, you're nervous that casting in itself isn't going to actually do the job. Okay, so this is sort of a belts and suspenders approach. Now keep in mind, as these long bones heal, I put this slide back in here because I want you to keep in mind that they maintain this moment of inertia as they regenerate. They regenerate in a way that allows the hollow part to stay hollow, and as they heal, they push more of the mass further away from the central axis so that the moment of inertia is maintained. So that the most of the mass as these bones heal are pushed further away to preserve that resistance to bending. The bones just know to do that. I lied, Carrie. Could I have the lights one more time? So if you look at this picture, this is a break, and here's early callus formation. You see that sort of halo cloud?
Yeah.
This is a intramedullary nail that actually goes down the medullary cavity. And so that's another open reduction approach where instead of an external fixator, you just put a rod down the medullary space to reinforce it, okay, allow it to heal. And this is 9 months later. You can see they removed the nail. It's not like it disintegrates. Okay, they removed the nail, and you see the halo effect here?
Yeah.
You can still appreciate where the break was. Right? You see how it's kind of, it almost looks like a knee. Right? So it's thicker, to answer your original question. When they heal, they sort of overcompensate the overgrowth. That'll slowly remodel over time, and the bone kind of shave it down a little bit. But an orthopedic surgeon with a keen eye would be able to, if you had an aggressive break and it's even years old, they could probably see a current x-ray and tell you exactly where it broke. Because they would see a scar just like you see on your skin. Because the bone heals like skin heals, and it creates a fibrous scar, and you can actually see where that is, just like you can see a scar on your skin years and years later. Okay?
Does that mean the bone is permanently weakened for the rest of your life?
No, this bone is stronger here, and likely would never break in the same location.
Oh, really?
Yeah.
So does that mean in a very,
It'll break like here or here, right?
So does that mean in a very bizarre way that sometimes breaking a bone can be good long term because the wall is become stronger long term?
I mean, one can make that argument, I think. I would prefer to have more milk and cheese.
Oh, no. I know. I'm just saying.
So let's talk about that. Let me put the lights back up. Let's segue into healthy bones. Okay, that's part 2. Healthy bones. In contrast, what are diseased bones? What do they look like? Well, here's a healthy bone. Here's a diseased bone. And this is a process known as osteoporosis. This is a term that means a loss in bone mass, a loss in the cancellous tissue of the bone. It's most common in elderly women. Most, meaning not only in elderly women. So men still experience osteoporosis, it's just a delayed onset. The onset for women, the trigger point, the cliff, happens to be menopause. So menopause is a phase in a woman's life where the menstrual cycle stops. They stop making large amounts or homeostatic levels of estrogen. And estrogen has a bone-protecting effect. A bone-protecting effect, meaning that it saves and helps to keep the bone strong. Testosterone does the same thing. And testosterone in men tends to decrease as we age, but at a slow decrease. And in women, menopause hits right around the age of 50, plus or minus 10. Early onsets of menopause would be 40, later onset would be 60. But when menopause hits and the menstrual cycle stops, estrogen levels plummet. And that's where this trigger point is for osteoporosis. So we talk about some preventions, and we're going to talk about some drugs that are used. But before we go there, just a picture and higher view of the density is less here and definitely more significant on the left side. So normal bone versus osteoporotic bone. Some facts and figures for us. Osteoporosis is defined as a disease that leads to an increased risk of fracture. So if a patient has osteoporosis, it doesn't mean that they are breaking bones all the time. It means that if they were to fall, their bone is less dense, so it's more likely to fracture. It doesn't mean that it will, and that's why prevention is a big deal. Okay? The bone mineral density is reduced, and the amount and the variety of collagen proteins in the bone is altered. Our friends at the World Health Organization say, by definition, it's defined in women as a bone mineral density 2.5 standard deviations below peak bone mass. Peak bone mass happens when you're in this classroom. Okay? Almost. 20-year-old healthy female is where the average peak is for bone mineral density for women. Okay? So you're at the prime of when your bone mineral density is going to be the greatest, or the largest. And this is measured, how do you measure? This is a fancy x-ray machine. It's called dual x-ray absorptiometry, DEXA. It's an x-ray machine that takes a picture of the bone, and from the image you can determine the density of the bone. So osteoporosis is most common in women after menopause, and we refer to it as postmenopausal osteoporosis. It may develop in men, and it can occur in anyone that has a particular hormonal disorder, or a chronic disease, or someone who's on a medication that has an influence of hormonal levels. So you can see the trigger, or the Achilles heel, is sex hormone levels in both men and women. So if there's a hormonal abnormality, an endocrine abnormality, that could manifest itself in less dense bones and early onset of osteoporosis. So this just kind of goes on to talk more about some of those types of characteristics. So some more facts. In our country alone, nearly 10 million people already have it. And this number is growing because our patient population is getting older. Another 18 million have low bone mass that puts them at a risk of developing osteoporosis. So they're not 2.5 standard deviations below the peak. They might be like 1.75. But they're in a high-risk category. 80% of those with osteoporosis are women. That means 20% are men. Okay, so it's not a women-only disease. It's predominantly women because of this tie to menopause. But you can see of older people beyond 50 years of age, which is looking younger and younger every year, 1 in 2 women, so 50%, right, and 1 in 8 men are predicted to have an osteoporotic-related fracture, meaning they fall and they break a bone, and the doctor says it's because your bone density is too low. That's an osteoporotic-related fracture. So what do we do about this? This is where we have some treatments. Okay? Well, we've got estrogen replacement, and I'm sure you've heard about some of these. Estrogen replacements slow or stop bone loss. You can take them orally or through the skin, transdermally with a patch. But some patients, specifically women, who are at risk of breast cancer, because this is also the age group where breast cancer can be prevalent in women, you don't want to deliver estrogen to a at-risk breast cancer patient, woman, because the breast cancer will respond to the estrogen and get more aggressive. Okay, so for example, breast cancer risk patients, the second bullet point, what we do is we'll actually prescribe these SERMs. These are receptor modulators where you don't increase the amount of estrogen. You simply say, I'm going to make the receptor to estrogen more sensitive, and then any estrogen that's available will be more likely to respond to the receptor, and that's a way to look at it from the other side of the equation. So estrogen receptors that are modulated via drugs like rafloxacin. You give patients extra levels of calcium and vitamin D. That should make sense to you now. Probably many of your mothers or grandmothers are taking a vitamin D or a calcium supplement. The people that put it in the little chocolate squares are brilliant, right? Then we'll give things like bisphosphonates, and you can see some examples of bisphosphonates. And these things help with the starting ingredient of bone on the inorganic side, the phosphates, and allow the building blocks to be available. So now you kind of see you're starting to throw all different sorts of things at it. And you probably have heard some of these like Fosamax or Boniva. These are the bisphosphonates that help stimulate osteoblastic activity. So now you are equipped with enough knowledge to be able to look at the packages of some of these products and go, oh, I see what their strategy is. They're actually stimulating osteoblastic activity by providing more starting material to build bone. They're increasing vitamin D, they're increasing calcium. Why vitamin D and calcium? You want the vitamin D so that the calcium isn't wasted in the urine and it's absorbed up into the bloodstream. And then calcitonin. This is a hormone that's extracted from salmon, and that actually does slow bone loss. So these are all of the, not the whole list, but many of the ones that you're probably going to run into as you deal with family members or as you in the future deal with patients. Now, this is a side tangent, but it's interesting to me. There's some companies that have decided to modulate bone and use it for some of their appliances. So, for example, this is a company that makes a infused bone graft, right? And this is a lumbar fusion device. So if you have two lumbar vertebrae that are weak and you're going to fuse them together, you're going to put, some appliances in there, and they impregnate these with a recombinant, right? That means they made it in the lab. Bone morphogenic protein version 2, BMP2. Recombinant bone morphogenic protein, that's what the RH is recombinant. BMP2 is a growth factor that stimulates osteoblasts. So they're putting essentially a drug on their hardware, so when it goes into the body, it in location triggers osteoblastic activity. This is kind of cool. Well, where does this also play a role? Well, hip implants. So if we look at our patients that have hip implants, they're typically titanium, and they have sort of two different components to them. They usually have, this is a hip implant, this is our femoral head replacement, and then this is actually the part that is hammered in to the proximal portion of the femur. And it's like legitimately pre-drilling, right? And they put it out there and like, can you turn up the music? I can't hear now because they're like hammering. Okay? So that now you want incorporation of that bone into the metal. So you're going to start seeing, in my opinion, my prediction, is a lot of these drugs or these therapies in other locations other than just on this fusion device as things continue to progress. So let's look at an example together of a sort of a clinical situation. This is a patient. This came from a friend who's a salesperson for an orthopedic company. So this is a real case that he worked on. MG is an independent 78-year-old who fell on the dance floor at her daughter's wedding. Okay? So, I know, isn't that kind of, can you picture her, like, grooving and moving? She was unable to walk and complained of moderate pain about her left groin and thigh. Examination at the emergency department revealed good range of motion of the left hip. Although it was painful, no deformity was noted. And so, Carrie, I totally lied. I need the lights down again. I got like X-rays out the wazoo apparently in this lecture. So here's MG. Okay, MG. What hip was it? Her left. What's on her right? That's a total hip that she had 9 years ago when she was a spry young lady, right? 9 years ago at 68. Okay, 69, excuse me, 69. This is biology, not math. So 9 years ago at 69, she had this right hip replacement. She's obviously postmenopausal at 78. Okay, she's outside of that range. You don't even really have to ask. But of course you would. So let's zoom in a little bit, and let's take a look at the left hip. So here you can see some images of the left hip, and the arrows, if you can't see them, are kind of helping you identify where this new fracture is. And if we rotate it in a different plane, right, and that's why they take pictures and, you know, they say, I'm going to have you stand this way, now turn this way, because they want to see if they rotate it, you can see when the hip opens up a little bit, you can see right here a very clear fracture. Not commuted, it didn't shatter, even though she's elderly, which is nice. And so the solution was actually an appliance that looks like this, where they didn't, in this case, compromise the entire femoral head. And so what would they have done? They like take a bone saw and go, right? And then they drill in and they put in a new femoral head. But they left this in place, which is nice because it reduces the possibility of like wear and tear on bone, in the hip, or metal on bone, if they keep the native architecture. So this will stay in place, okay? Here you can see it rotated slightly, and just to prove to you that the fracture is still there. So this is immediately after placement. Right there is that little fracture, and this is the new appliance to reinforce. So open or closed reduction? Oh, for sure, right? They'd be like Houdini if they were able to put this in a closed situation. So here's what I want you guys to talk about for a minute. I want you to talk about these questions. She's currently on aspirin and Coumadin. This is kind of where we start to integrate a little bit. She has high blood pressure, and I want you to forecast or guess what kind of gait or walking issues do you expect. What kind of dietary suggestions can you make to her when she goes home? And what are you going to suggest with respect to exercise? And if you got any ideas, what types? So talk about that. I'd like to hear from a few of you. So let's have a couple of volunteers take bullet point, the second bullet point, another one take the third, and another one take the last one. So think ahead. What would you like to talk about? Who's got an idea for the first one, which is what type of gait issues? Walking or, running or dancing, apparently. We need to worry about that with her. Right? Don't dance in the bathtub. Any volunteers? Right here. Yeah.
So it's going to grow and develop more on the left side.
Right, so she's going to have to sort of, she'll be compensating as she walks. She'll probably have a walker at first. Probably in a wheelchair initially. But are you going to want to, if you're going into PT, are you fine, like, you know what, just stay in the wheelchair, don't worry about it? Why are you wanting to get her out of the wheelchair?
Some of the osteoclasts will take over and eat her bone.
So the osteoclasts don't take over. You want to stimulate weight bearing, right? You get into a walker, she's compensating. You want to eventually get her balance stable enough where she can get rid of the walker, plus it looks goofy on the dance floor. Okay? But these are definitely the gait issues that you're going to be dealing with real patients like this after the surgeon if you're going to be a PT. Right? And then you're going to have to explain to her why. And if you can explain to her, like, here's why I want you out of the wheelchair as soon as we can, as soon as it's safe, because that means that bone's going to respond quicker if we put weight on it. You understand that now, but she's not going to know that. Okay? She's just going to want you to turn up the music. What about this bullet point, diet? What's some diet ideas you have?
Lots of calcium.
Okay, let's hear some other folks. Lots of calcium, I agree. What else? What's that? Low sodium. Why low sodium? She has high blood pressure. Okay? You want to avoid vitamin K, because that's a natural anticoagulant, and she's already on aspirin and Coumadin. Okay? What about exercises? Someone new, or you haven't gone yet. That's fine. We're dominated by the front row, though.
I would say either passive exercises, like you have somebody else do the joint at first,
Okay?
or going on short walks, or I volunteered in a PT office before, and they'll have people who have these devices on their side use what's called a space treadmill, and it's they put a bag of air around the lower half of your extremity, so it increases the movement, but it's less weight bearing, so it's less painful.
So it's safer. Yeah, yeah. So you're gonna want weight bearing as much as she can tolerate. Yeah. Swimming would be great once the wounds have healed and she's cleared to take a shower or a bath and to get into a pool, right? Because it kind of accomplishes some of the same things as this young lady said. What about outside versus inside? Any ideas? Why outside? Get vitamin D from the sunlight, right? You can explain to her why that's so important. Look at all the cool things that you know now. Okay? So this was some groundbreaking research that happened a while ago by some pretty impressive guys. Langer and McConney are sort of these fathers of tissue engineering. And what I want to show you is I want to show you where the field is going. Okay, these guys were pioneers and we're still working on this stuff. But here we've got a model. I'm going to focus on this bottom slide, bottom picture. We've got a model where we created a defect in bone, in an animal model. They did. Okay? And you can see that's nicely delineated by this plate and these screws. And there's the defect. Right after operation, when they cut the defect, they put in a scaffold. This was a hydroxyapatite, which is like a bone mineral replacement, and a tricalcium phosphate. So an HATCP scaffold with no cells. They put in a scaffold with mesenchymal stem cells, bone stem cells. They waited 8 weeks and then 16 weeks. In the empty defect, after 8 weeks and even 16 weeks, it was still unhealed, still wide open. In the one that had just the scaffold, you could see that it was closed up, but if you see the intensity of the density, meaning this whiteness compared to this whiteness, the bone cells, stem cells, plus the matrix help to regenerate the bone to a greater extent. You have, and this is exactly what I was talking about, this would be denser bone here and denser bone here compared to here. Can you appreciate the qualitative differences between less dense and more dense?
Oh, yeah.
Yeah. Okay? So we're playing around in the space now with these types of capabilities. How to modulate bone as we heal. So in the last little segment for today, let's talk about some bone health issues. Bone health is this balance between a number of different things. Right? We've got excessive bone resorption. what cells would be dominating excessive bone resorption? Osteoclasts. Inadequate new bone formation during remodeling. What cells are a problem there? Osteoblasts. And then inadequate peak bone mass. Remember how I talked about it earlier? So answer this question. What's the most important age group to be thinking about when you're talking about actions to prevent osteoporosis? 41 to 60 is too late. 21 to 40 is too late, man. It's when they're young, right? Because what happens is this. This is what happens is the bone increases in size and you get to the peak bone mass in your 20s. And it plateaus for a while. And then this is the over-the-hill part, right? Okay, so at 40 is where things start declining. So the idea is this. Okay, stay with me. Here's the idea. Is a graph of calcium intake at age. If you know that you're on a decreasing bone density graph slide, so to speak, and you go from situation B, and you hit menopause, you quickly moved into a high-risk category. Versus if you do things earlier in life, like weight-bearing activities and exercise, appropriate dietary intake of calcium and vitamin D, you start your life in your 20s and 30s with a higher level of bone density. So when you hit this graph of decreasing bone loss, you actually stay in a low-risk category or a no-risk category for a longer period of time. This is really the idea about education and prevention. Okay? This is the last slide that we're going to cover. We're going to stop here. Okay? And this is what's on the exam up to this point on Monday. Okay, Karen, can I have the lights back up?